start recording. Oh, we also have Abigail Hodgson. I don't believe she was on last time. She's our new administrative assistant for the Center for Medical Cannabis. Welcome. And it looks like we do have a quorum.
Yeah, Sarah, and as long as we're on introductions, why don't we
that was the first thing, yeah.
Yeah, Dr. Chan and Dr. Cashin introduce themselves. We would welcome them to this board. Would you like to start, Dr. Chan?
Sure. My name is Dr. Melissa Chan. I'm a family medicine doc. Yeah. Happy to be here.
Great. And where do you practice?
Salt Lake City.
Okay, great.
And can you mention, you worked with a large health organization in California to help establish medical cannabis use in their facility. Is that correct? Their policies? Dr. Chan?
Yes.
Okay.
A very large, well-known organization. Yes, I don't know if you want me to name drop, but it's a very large, everyone's heard of them. So I assisted with bringing about how, especially with California and, early on, before it became recreational, of how do we do this in a large system, and how do we disseminate this information to physicians? How do we create policies? Yeah. So,
thank you.
Perfect. That's really relevant to our board here. So that's great. Welcome.
Thank you.
And Dr. Cash, is it Cashin or how do you say it?
Just like it is, just like it looks, cash in.
Okay.
Although I haven't cashed in yet. So I have a PhD in nutritional psychology. My emphasis when I was doing my thesis was on medical cannabis as medicine. I've been teaching courses in medical cannabis at Utah Tech, well, formerly Dixie, for about 4 years now. But my main job is really teaching psychology at Mojave, and I have a full load this semester. But I actually teach cannabis as part of that course as well. I talk about the endocannabinoid system in that class.
Excellent. Well, welcome to both of you. I think you'll be great additions to this board and to our mission here. Well, Sarah, do we have, should we officially begin and do the welcome? Do we have to read the...
Sarah Dash, if you wouldn't mind presenting the agenda, please.
I need to have access to screen share. It says it's disabled for me.
Oh, I'm sorry. You're supposed to be...
Worries?
Oh, your co-host privileges when it got taken away. That's why.
No.
Okay, there you go. I fixed it.
All right. Thank you. All right, here's the agenda.
Yep.
Can you see that okay? Should I zoom in a little bit?
Yeah, just zoom into the far top part of the agenda. Perfect.
Yeah, so here's our agenda for today. And but I was wondering, Sarah, do we have that disclaimer we're supposed to read? This meeting,
the intro slides. Sure, yeah.
This meeting is taking place virtually, in case you didn't know. It's being held, hosted by the Utah Department of Health and Human Services in Salt Lake City. Public notice of this meeting was provided as required under Utah Open Meeting Code and posted on the Utah Public Notice website. Our purpose is to review the available research, literature, and assist the Utah Department of Health and Human Services and Center for Medical Cannabis in their efforts to provide useful treatment recommendations to qualified medical providers regarding the use of cannabis and cannabinoid products for the treatment of certain medical conditions identified as qualifying medical conditions. This meeting is being recorded in compliance with Utah's open meetings law. Recording this meeting will be posted to the Utah Public Notice website within 3 business days following the date of this meeting. Written minutes will also be prepared for this meeting. Approved minutes will be posted to the Utah Public Notice website within 3 business days after board approval. Here are the board members, which we just reviewed briefly and introduced our new staff and board members. Public comment period. You have 2 minutes to make a comment during the comment period of the meeting. Select the raise your hand function at the bottom right of the screen so that we can take comments in an orderly manner. State your name and if you have any affiliations to any business entity. And if you are affiliated, declare it and then state your question or comment. Okay, so we will allow all the comments to be added first, and then we will have a board comment after that. As a courtesy to everyone participating in this meeting, at the time, we request that you place yourself on mute unless you're speaking to the group. Board motions and votes will be recorded in the minutes. We will now turn our attention to the agenda. Okay. All right, so, well, great. So last time we missed approving some minutes. So let's get that function out of the way. With the May minutes, do you have the May minutes available? I hope board members have been able to review the minutes. In May, we talked about cannabis use disorder, I think. And yeah, there we go. So insomnia, cannabis use disorder presentation, which was really good. There's a summary, and then updates from Rich from the Center of Medical Cannabis. And then we talked about term endings, Dr. Carlson and Dr. Fine and Dr. Zender. So are there any corrections, additions, or edits to be made to the May minutes? No. Do I have a motion to approve the May minutes?
Motion to approve.
Great.
I'd second that.
Fantastic. Mike's motion, Misty second. All in favor of approving the May minutes, raise your hand or say aye. Excellent. Any opposed? Fantastic. Let's record the May minutes and move on to is it July's minutes? Here's a review of July minutes. Virtually, I conducted. We had to actually formally nominate the chair and vice chair for this next time period. And then we reviewed multiple sclerosis literature review by Lauren, which was excellent. Since July, we have been able to review the discussion and the recommendations. Hopefully we've done that so we can approve that today.
I believe I sent this out as a correction previously. I requested that I'm referred to Miss Smith throughout the text, and it should be Dr. Smith.
Okay.
It's a minor correction, but it would be appreciated.
That sounds great.
Absolutely. You've earned those credentials. We have to recognize those.
So we had the discussion on MS, which we'll finalize today. Okay. And then another update and comment. Great. Any other edits to the July minutes? Okay, no discussion. Do we have a motion to approve the minutes for July as edited?
Yeah, once we edit those
I
credentials.
move to approve this with the stated corrections.
Perfect. We have a second.
Second.
Mike second. They swapped roles. Perfect.
Teamwork.
All right. All in favor of passing the July minutes, raise your hand or say aye.
Aye.
Excellent. Any opposed? Fantastic. Motion passes. Okay, we're moving right along. So let's move to multiple sclerosis. Hopefully you had a chance to review the multiple sclerosis document that we revised and worked on last meeting. I think it was a significant update to our recommendations. Do we have any discussion about those, about the document, the recommendation guidance document for MS? Excellent. Well, I really appreciate.
Sorry, Dr. McGiff, if I may pose a question to the board about the guidance document. I noticed in the graded conclusions area, the one that's about non-MS spasms is still there, although the guidance document is focused on MS. I just wanted to check, do you want to keep that statement there or pull that out and then evaluate it when we evaluate the non-MS spasms?
Great, let's talk about that. Can you pull that up, Sarah, our proposed MS document? So what Lauren's referring to is at the end of the guidelines, well, the first guidelines, when were they? 2019 or whenever they were added, had a statement about what was it? Paralysis? What was the statement? Yeah, spasticity in patients with paralysis due to spinal cord injury. So that was included in the first document, and we just left it in there for this document. So Lauren's asking, do we keep that or do we take that out? We added, just to review, we added, before there was only the evidence about spasticity, the first one, and then the second one about neuropathic pain. We added limited evidence about overactive bladder symptoms and insufficient evidence about tremor. So that's what we added. And then we just left in this paralysis statement. Lauren's question is valid. Do we take that out because it just does, it refers to spinal cord injury rather than MS?
And that we could, that will lead into our next question, because if the board decided we're going to do a guidance document on persistent muscle spasm. So we're wondering, you know, where our scope should be on the persistent muscle spasm as well. Do we include things that are not necessarily considered spasticity, such as I don't know, Parkinson's movements, things like that. That was a question that Lauren had as well, because the scope is quite huge when you go into what people consider persistent muscle spasm. And Lauren, you could probably word it better than I did, if you want to explain a little more what your question is.
Sure, I can explain more about my question. As Sarah was saying, the scope can be huge if you consider spasticity as well as other things that I think are considered not spasticity, more dystonic reactions, or other Parkinson's like rigidity or other types of symptoms. I had been leaning towards just excluding everything that didn't report an endpoint of spasm or spasticity, and that would end up excluding Parkinson's disease, as well as like a lot of like focal dystonia type syndromes. But even when you just look at spasms and spasticity, there it can be quite a lot of literature of different disorders, like spinal cord injury, cerebral palsy. There's just a number of things. So I think Sarah just wanted to get some feedback from the board about what you'd be interested in seeing in terms of conditions in that document. And I was also wondering one specific question. I came across some articles that it's a mixed population, which includes people with MS spasticity as well as other conditions, primarily spasticity from spinal cord injury. They report the outcome together for both MS patients and spinal cord patients. I would probably exclude those because I wouldn't be able to isolate the non-MS spasticity, but I wanted to get your thoughts and feedback on that.
So
Sorry,
the
that was
question is, this is a this is a qualifying medical condition and it's listed as multiple sclerosis or persistent and debilitating muscle spasms instead of spasticity, which is kind of unfortunate. And are we saying we are going to do a separate review of that chunk and just how to define it, and then we remove it from the MS discussion? So MS is just MS, and then everything that's not that goes to a separate document and review. Is that the question? And then part two is, what is the scope of spasm and spasticity?
Yes.
Thank you.
And we can take this offline and do more discussion via email if that's better. If people want more time to think about it.
I think it at least makes sense to detach MS. I realize it's kind of listed together as the qualifying medical conditions, but obviously it ends up being one very specific condition and then a very broad category of other things that could be defined as a persistent spasm instead of spasticity. So I think it would make sense for the document to be separate. And then exactly how do we parse down those details of spasm versus spasticity versus dystonia? Maybe we need to ask a neurologist, but I think at least having them be separate documents certainly makes sense. I don't know. I agree, Lauren, of how do you make it as fine a point as possible, but then still apply it to anyone for a qualified medical provider who's trying to figure out if their patient should get it for a quote spasm or not. We want to be as helpful as we can to everyone out there trying to figure out what to do with their patients. And maybe that's a bit more discussion. I don't know that I'm prepared to talk in detail about that right now.
I would agree with Dr. Moss and Dr. Heath that it is definitely a separate discussion. But I think, Lauren, you can probably comment here. Having glanced through the literature a little bit, there's definitely less to look at when it comes to non-MS spasms. The literature is very heavily weighted towards MS specifically. So I think it's going to be much more difficult to find controlled clinical trials for certain, but research in general on the non-MS spasm-related experiments with cannabis and cannabis products.
Great. So maybe we just need to continue this more offline. I'll set up an email discussion so we can kind of help Lauren refine her scope for the spastic or the persistent muscle spasm guidance document. But at this time, do we want to strike that last point about spasticity and paralysis and spinal cord injury from the multiple sclerosis document? Or leave it?
I would say until we have something to replace it, it might not harm anything to leave it.
Yeah.
Because we don't have anything to refute that statement.
That's a fair point. I've gone both ways on this, but I think that's a fair point. Until we have something better, we could just leave it.
I agree.
That seems like a good medium of leave it and then replace it, and it can be our placeholder for the meantime with a goal of making it more separate and distinct and better reviewed later.
Okay, great. Are we ready to approve?
Okay, yeah, if there's no further discussions, do we have a motion to approve this guidance document?
I'll move to approve it.
I'll move to second.
Fantastic. Dr. Smith motion, and was that Dr. Cashin second?
Yep.
All right, we have a motion with a second. All in favor to accept this document as is? Raise your hand or say aye. All right, any opposed?
And thank you, Dr. Heath, for doing such a wonderful job again.
Yeah, I echo that. That was fantastic. I love that. And now we get to hear about Crohn's disease and ulcerative colitis, which again was fantastic. But without further ado, let's turn the time over to Dr. Heath and take us through.
All right, thank you. Sarah, should I be sharing my own screen?
I can share it if you'd prefer that.
I can share mine. I just wasn't sure how it was set up. It looks like I can share it though.
Yeah, I've given you privileges. You should be able to share.
All right, well, let me know if you can't see that. Hi, everyone. I'm Lauren, and I'm a pharmacist working with the Center for Medical Cannabis. And today I'll be giving an overview of randomized control trial evidence for the treatment of inflammatory bowel diseases with cannabis-based products. A goal of this review is to help the Utah Cannabis Research Review Board, or CRRB, update current guidance on the treatment of ulcerative colitis or Crohn's disease with medical cannabis. To complete the review, I searched for relevant systematic reviews of randomized controlled trials, abbreviated RCTs, published since 2018, or RCTs published since 2022. I considered any type of cannabis or cannabinoid intervention and summarized key efficacy and safety results. Note that all RCT evidence is from the same research group in Israel, except for one multi-site trial from a group in the United Kingdom among patients with ulcerative colitis. Due to the similar investigators and interventions, it was pretty difficult to verify that each included trial was unique, but I did my best to verify that and represent unique trials. I just wanted to have that disclaimer. Prior guidance from the CRRB on this topic was based on 2 high-quality Cochrane organization systematic reviews of RCTs published by Caffel et al. For both the treatment of ulcerative colitis and Crohn's disease, Caffel et al. Concluded the effects of cannabis or cannabinoids are uncertain. In the coming slides, I'll summarize both RCT evidence that had been included in these prior reviews and therefore considered for the prior CRRB guidance, and additional RCT evidence that I found for this review. I included 4 8 to 10 week placebo-controlled RCTs for the treatment of active ulcerative colitis with a cannabis or cannabinoid product. 2 of these RCTs, Irving et al. 2018 and Naftali et al. 2021, were included by the Caffel et al. Review. So there's 2 new RCTs. Overall, these trials included 121 adult patients, with most patients having mild to moderate disease. 2 trials excluded patients with current cannabis use, and 2 trials allowed patients to continue stable doses of disease-modifying ulcerative colitis medications. The trial required patients to have failed, one trial required patients to have failed prior therapy, and another trial required patients to have failed prior therapy or be on a stable dose of 5-aminosalicylic acid, which is a first-line therapy for mild disease at that time. 3 trials studied THC-predominant cannabis cigarettes, and 1 trial used an oral CBD-rich botanical extract. And 2 trials evaluated by a systematic review were considered to have a high risk of bias, and 1 was rated as having a low risk of bias. Each trial evaluated ulcerative colitis disease activity using various disease activity indexes, which account for common symptoms or findings depending on the scale, such as stool frequency, rectal bleeding, abdominal pain, general well-being, or global medical assessment. 2 trials of THC-rich smoked cannabis showed a significant reduction in the disease activity versus placebo, while the other trials did not test for or did not demonstrate superiority. However, the direction of the effect for these other trials favored cannabis. A subset of trials evaluated clinical remission or response based on reaching a threshold reduction in the disease activity score. CBD-rich oral cannabis failed to induce clinical remission or clinical response versus placebo, and THC-rich cannabis only descriptively improved remission rates in 1 trial. A few trials evaluated for changes in the colon mucosa by endoscopy. A numerically greater proportion of patients receiving oral CBD-rich cannabis had improved mucosal disease at 67% versus 39% in the placebo group. But this failed to reach statistical significance. After 8 weeks of treatment with THC-rich cannabis, endoscopy scores were not significantly different from placebo in 1 trial, and they were described as improved in the 2nd trial. 3 trials evaluated various inflammatory markers, such as the systemic C-reactive protein and fecal calprotectin levels, which correlates with inflammation in the gut. CBD-rich oral cannabis failed to significantly reduce various systemic inflammatory markers and fecal calprotectin levels. THC-rich smoked cannabis did not significantly reduce fecal calprotectin levels from baseline to 8 weeks in one trial and demonstrated mixed effects of increased CRP and decreased CRP in 2 trials. The reduction in CRP levels with THC-rich cannabis relative to placebo may have been statistically significant in one trial, but it's uncertain due to lack of reporting clarity by the investigators. 3 of 4 trials measured patient-reported quality of life. CBD predominant oral cannabis treatment did not significantly change the IBD specific patient-reported quality of life score relative to placebo in the trial's intention to treat analysis. However, total scores were significantly improved in the other per protocol analysis. Numerical differences from baseline favoring cannabis emerged for the bowel symptoms, emotional status, and social functioning subdomains, but not for the systemic symptoms subdomain. Additionally, a significantly greater proportion of patients who received cannabis endorsed generally feeling better than the placebo arm in both the intention to treat and per protocol analyses. 2 THC-rich cannabis trials demonstrated significantly greater improvement in patient-reported quality of life by the general SF-36 survey from baseline to 8 weeks compared to placebo. It's unclear whether the differences observed in these trials are, the statistically significant differences are clinically significant, particularly for the THC-rich cannabis trials that did not report physical and mental component subscale scores for that SF-36 survey. But the exact numerical value changes for the mean IBDQ total scores were not reported in the CBD-rich cannabis trial, but the change in the cannabis arm appears to exceed the minimally important difference of 16 that I found reported in the literature. Safety information was not reported by each trial. Generally, CBD-rich oral cannabis was not well tolerated by participants. 45% of participants discontinued the cannabis treatment, often due to dizziness. Fewer participants in the placebo arm discontinued the treatment, though notably discontinuations in the placebo arm were mostly due to persistent GI symptoms, which could be characteristic of ulcerative colitis. 2 THC-rich smoked cannabis trials considered most adverse events as being mild to moderate in severity. Select adverse events from the THC-rich cannabis trial that potentially use the highest THC dose are shown in the bottom row of this table. Notably, one of the adverse events was difficulty stopping use, which occurred in 29% of the cannabis arm, compared with 12% of the placebo arm. Okay, so moving on to Crohn's disease, I included 7 8-week placebo-controlled RCTs of cannabis-based interventions for the treatment of adults with active Crohn's disease. 3 of these trials were addressed in the prior review by Cathal and colleagues, and 3 trials are available as an abstract only. Overall, these trials included 242 patients, primarily with mild or moderate disease, though patients with moderately severe disease were allowed in at least 2 trials. In at least 3 trials, patients were required to have failed at least 1 prior disease-modifying therapy, and at least 4 trials allowed patients to continue stable doses of Crohn's disease medications. 2 trials studied smoked THC-rich cannabis twice daily. The THC dose was apparently very high at 115 milligrams twice daily in one trial. Oral cannabis extract containing about a 4-to-1 ratio of CBD to THC was used in 4 trials, and a sublingual low-dose CBD predominant oil was used in the remaining trial. 3 of 5 trials evaluated for risk of bias by a systematic review were considered to have a high risk of bias. 1 trial had some concerns, and the last trial was considered to have a low risk of bias. Like the ulcerative colitis trials, Crohn's disease activity was assessed using a disease severity index in all 7 trials, and only a subset of those trials reported achievement of clinical response or remission in disease activity per endoscopy. The Crohn's disease activity index assesses stool frequency, abdominal pain, general well-being, use of antidiarrheal medications, the presence of an abdominal mass, anemia, and weight status. 5 out of 7 trials reported statistically significant improvements in overall disease activity with cannabis over placebo. Changes in disease activity were not statistically significant in the remaining 2 trials, though the direction of the effect favored cannabis. THC-rich smoked cannabis was associated with greater rates of clinical remission in 2 trials. However, the difference versus placebo was not statistically significant in 1 trial, and the other trial did not formally assess for differences. Nonetheless, a significantly higher proportion of patients who received high-dose THC-rich cannabis reported clinical response, a higher clinical response than placebo in 1 trial. CBD-rich oil induced significantly higher rates of clinical remission than placebo in 1 trial, but not a 2nd trial. According to authors of the largest trial, which used CBD-rich cannabis oil, improvements in Crohn's disease activity were primarily attributable to improvements in general well-being and abdominal pain, and there were not significant improvements in bowel movement frequency with the cannabis treatment. 2 trials of CBD-rich oil failed to show differences in disease activity per endoscopy compared to placebo. 4 trials evaluated for the inflammatory marker C-reactive protein and/or fetal calprotectin. No significant differences versus placebo were seen for CRP or calprotectin. At the bottom of this slide are results from the largest trial. As you can see, CRP levels were relatively unchanged, and calprotectin levels may have declined slightly after 8 weeks of cannabis treatment, but there were not significant differences compared to placebo. Patient-reported quality of life was assessed in 5 of 7 trials, primarily using the general SF-36 survey. All 5 trials demonstrated either significantly greater improvements versus placebo or a significant increase from baseline in the cannabis-treated group. Results from the largest trial using CBD-rich cannabis oil are shown at the bottom. Median quality of life scores increased from 74 to 91 at 8 weeks in the cannabis arm, whereas scores were relatively unchanged in the placebo arm. Nonetheless, in this trial, the magnitude of improvement in quality of life score failed to reach the pre-specified threshold of 30 points, and the between-group difference in change in quality of life scores was no longer significant when it was corrected for age, gender, and duration of Crohn's illness. Adverse event details were underreported by trials. 2 trials of the THC-rich cannabis reported no serious adverse events, and 1 trial using high-dose THC-rich cannabis reported events including sleepiness, nausea, concentration, memory loss, confusion, and dizziness, without apparently significant differences in the rate of these events versus placebo. Low-dose CBD predominant oil was associated with headache, sleepiness, nausea, and dizziness at rates similar to placebo. And in another trial using CBD-rich oil, visual distortion, behavioral changes, confusion, decreased memory, and dizziness occurred with an incidence at least 5% higher than placebo. All right, so that was a lot of information, but in summary, this evidence review addresses 9 RCTs, including 4 among adults with active ulcerative colitis, totaling 121 patients, and 7 among patients with active Crohn's disease, totaling 242 patients. 4 RCTs, or 5 if you count 1 full-text RCT that was previously only published as an abstract, were included that had not been addressed by prior CRRB guidance. There are limitations to the body of evidence, including that the trials were pretty small, lasted only 8 to 10 weeks, studied heterogeneous cannabis products and regimens, and were primarily conducted by the same research group. In addition, 4 trials out of 7 trials evaluated by a systematic review are considered to have a high risk of bias. Overall, the RCT evidence suggests that cannabis may improve some inflammatory bowel disease symptoms in the short term. However, there's insufficient evidence to conclude that cannabis significantly improves clinical remission or response. Short-term cannabis did not improve markers of inflammation or lesions in the gastrointestinal tract in most cases, suggesting the possibility that any benefits from cannabis may not be from reducing inflammation. Most trials that measured patient-reported quality of life demonstrated significant improvements with short-term cannabis over placebo. And unfortunately, adverse event information was underreported by trials, but based on available information, short-term cannabis use seems to be associated with primarily mild to moderate severity events. I also I found this 2022 International Organization for the Study of Inflammatory Bowel Diseases had an expert panel that made recommendations, so I wanted to mention that to you. So they convened this expert panel on lifestyle, behavioral, and environmental modifications for the management of inflammatory bowel diseases. They suggested against treatment of ulcerative colitis or Crohn's disease with cannabis or cannabinoids with 76% agreement, given the lack of robust evidence of clinical or endoscopic benefits. So current CRRB guidance for the treatment of inflammatory bowel diseases with medical cannabis includes one graded conclusion that there's insufficient evidence that cannabis is effective or ineffective for ulcerative colitis or Crohn's disease treatment in general. I included just some things for your consideration as you're deciding what changes, if any, you want to make to the CRRB guidance document. So to update current guidance, the CRRB may consider drafting formal conclusions for ulcerative colitis and Crohn's disease or certain outcomes separately. For example, you may consider addressing outcomes of inflammation, clinical and endoscopic remission or response, and patient-reported quality of life, or additional outcomes. It's my opinion that evidence is insufficient for the outcomes of inflammation and clinical and endoscopic remission or response, since the statistical significance of findings are mixed, or the endpoint was only reported by one trial. In contrast, since cannabis had a fairly consistent positive impact on patient-reported quality of life among trials, reporting that outcome, you may consider rating the evidence for that outcome as limited. Nonetheless, given general concerns about the risk of bias among most trials, and depending on your interpretation of the evidence, you may also consider the evidence for quality of life as insufficient. If you do choose to draft new graded conclusions, I suggest including in the statement the evidence is among patients with active disease after short-term treatment and listing the types of cannabis studied. Since all evidence is among patients with active disease, you could also consider adding a conclusion that there is no evidence regarding use of cannabis for patients with inactive ulcerative colitis or Crohn's disease, including, for the maintenance of disease remission. In addition to graded conclusions as elaboration in the guidance document, the board may consider describing who the RCT evidence is most applicable to and suggestions for how to use cannabis. And I just included some example considerations on this slide. I think some of these are already addressed in current guidance, but you could integrate in some of the new findings with that. These are the references, and that's all I have for the presentation. I'm happy to take any questions if you have them at this time.
Lauren, I have a question for you just on that consensus guideline, more or less said insufficient to really say much of anything. But it seems from your review, you say there is maybe some limited evidence for patient-reported improvement. What do you think is the reason for the discrepancy between their overall statement and some of the positive findings that you came across?
Well, I think understandably they're focused on the outcomes of clinical remission or response and endoscopic improvement. And I was looking at broader outcomes that I saw reported consistently in the literature. which is why I was thinking if you wanted to, in the guidance document, you could consider evaluating some of the outcomes separately to show, what the literature might be saying about different outcomes. However, I think what the international organization is saying is true and valid. Those are important outcomes in terms of the treatment of Crohn's disease and ulcerative colitis. I also don't know, they don't clarify in the document if they were considering cannabis as like an adjunctive treatment to other disease modifying therapies or as a replacement for disease modifying therapies. I think it's possible they're saying, we're based on the available evidence that we don't have that cannabis induces remission of disease. We don't want it to be like a replacement for evidence-based therapies that we have. Does that address your question?
Yeah, that's great. I think, we have IBD as a qualifying medical condition, which lends it some sort of support anyway from the legislature or otherwise. And then we're left to say, maybe shine a little bit more light on what that role is rather than insufficient to say anything. And so I think having a little more specificity of short-term quality of life improvement, recognizing that IBD is not a short-term disease, and what is the impact of short-term quality of life improvement and not remission and long-term outcomes, which I think probably that panel is looking at, thinking this is a disease of years and decades and not a study that lasts a few weeks or months. And that's understandable, but I suppose we could highlight what that difference is and then compare it to what are the approved cannabis forms that we have in Utah compared to what has been studied, whether this was smoked cannabis or more CBD rich. And so people can understand which of the forms they might choose that we have available that would be supported by some of the evidence. So I think I'd be in support of expanding some of that statement, even if overall there's a limited or insufficient evidence overall. At least detailing some of those specifics I think would be helpful and could still be in line with the prior statement.
And I like the idea of considering cannabis as an adjunctive therapy, not replacement therapy. I think that makes a lot of sense based on the evidence and my own experience working with educating patients or individuals who have had IBD related issues. Cannabis was never the primary treatment, just an adjunctive treatment.
Agreed. I believe it's important to acknowledge the quality of life improvements that were observed for the short term, at least, for completeness of the report. So I like Lauren's recommendations for the more detailed additions to the statement.
I concur with that too.
I also think it's important, as she mentioned, to specify the forms that were utilized in the studies, just so there's clarity.
A question about that, since many of the studies involved cigarettes and smoking, how would we equate that to what we offer in Utah? Would we look at vaping as an equivalent, or would we just go with the oral administration side of it?
I think that's part of the reason why it's important to clarify what was actually studied, because it doesn't directly correlate with what is approved in the state of Utah.
I agree with all these comments. These are exactly what I was thinking as well. I think it's helpful. We want to be helpful, and the guidance document right now isn't really helpful. It's an approved condition in Utah, but our guidance isn't really helpful just to say it isn't insufficient evidence. So I like delineating the different outcomes and acknowledging some of the successes that's been shown, but also acknowledging the problem. This is a heterogeneous body of evidence with heterogeneous products, so I think to help clinicians, again, this guidance document is for clinicians and to help them, let them in on the problem. Well, here are all the problems with the research, but here's what we do know so far, and here's what, so I agree with all that's been said. And if we can somehow condense that down into a a helpful statement. And also, like you said, the adverse effects weren't adequately reported. And those high doses, you know, CBD at 250 milligrams daily, yeah, that's a lot. I'd be dizzy too, right? So maybe at lower doses, it could serve more as an adjunct. You know, I'm guessing they use that dose to see if they could be a disease modifying or a replacement therapy. But like Dr. Cashin said, these are mostly beneficial for adjunct therapies. And so you don't need that high of a dose for an adjunctive therapy.
Agreed.
So if we could just, you know, organize this in a way to a clinician can read it and say, oh, okay, I get it. It would be very helpful. Any other comment? Dr. Chan, do you have any response as well?
I agree with everything that's been said. So I've been like nodding my head. Yes, making it more clear in terms of just saying, just flushing it out more and just helping clinicians quickly reference. I agree with everything.
So thanks again, Dr. Heath, for all this work. I think it's kind of interesting to note that identifying the problem, you know, reading through your summary last week made my head spin, how you all this potential benefit, but then, you know, these conflicting and mixed evidence. But I think letting people in on the problem is somewhat helpful. Showing them how complex this is sometimes helpful. So.
We also invited some QMPs to this discussion that had provided medical cannabis cards to patients that have Crohn's or ulcerative colitis symptoms or disease. Did we want to invite them to make any comments at this time?
Sure. This is a specific discussion regarding this topic. So, and they were invited guests. So yeah, let's open it up to them. Sarah, if you could direct that.
Do we have any QMPs that would like to add some comments about treatment with cannabis?
Specifically for ulcerative colitis and Crohn's.
Correct.
So I guess the same process would be in order. If you have a comment, you're an invited guest, please select the raise your hand function on the Zoom if you would like to contribute to this discussion.
All right. If not, you're always welcome to email us at medicalcannabis@utah.gov later on if you come up with any other thoughts or suggestions. So thank you for joining, though.
Awesome.
So I guess next steps, we'll just send out the document with the recommendations that were made today, and then the board can work on getting it to the point for approval.
Yep. So watch your email. This will be done mostly offline. Again, thank you, Lauren, for so much work, and we'll figure out how to condense this down into a helpful list or summary of recommendations and guidance. And then we'll have it ready for next meeting for approval, which next meeting will be what? Is it December or?
It'll be in January.
January.
Mm-hmm. And yeah, it'll be January. Oh, the second Tuesday. Unless there's a reason that we need to meet beforehand, but it should be January 9th will be our next meeting.
Great. So that'll give us plenty of time to go back and forth on this document and hammer it out to be useful. Okay. Well, if there's no more discussion on ulcerative colitis and Crohn's, well, and are we going to separate those two, Lauren? Was that your recommendation to treat them separately and not just together as IBD?
I included that just as a thought to put out there for the board because it is lumped together currently, but I do think the body of evidence is larger for Crohn's disease. So you could treat them separately, although the conclusions I ended up proposing to you, I think are valid, just as separate outcomes, but the two diseases together. So.
Well, it seems like the quality of life improvement was for both regardless, correct?
Yeah.
Lauren, could I ask one other question? And maybe this is getting a little too preclinical, but in your review of the studies, did they mention any additional work that they may not have included from the clinical trials, but looking at the oxidative stress or some of the oxidative changes, some of the pre-inflammatory changes that obviously contribute to inflammation? I know they used inflammatory markers as an endpoint in some of the studies, but there's also DNA methylation. There's also other changes that are sometimes are used as biomarkers of potential impact. Did they mention any of those?
From what I can recall, I didn't see any of those outcomes
Okay.
reported in these clinical RCTs. The only other outcome I saw in one trial, which I didn't talk about in my presentation, but it's in the report, is one of the trials looked at correlations with levels of different endogenous, parts of the endocannabinoid system. They looked at how taking these medications correlated with changes in the levels of the endocannabinoid system. But other than that, no, I don't think so.
I think in the end report, it'll also be important to state that additional research is still needed.
One
just-
area,
Oh, sorry. Go ahead, Dr.
one
Chen.
area I've heard patients who have Crohn's, I'm a QMP, who have Crohn's and ulcerative colitis, is they always tell me that they look for products that are high in CBG. Did you see anything with the CBGs?
If you look in the appendix of the report, if they detailed other components of cannabis, I tried to describe that. I didn't talk about it today. I think at least a couple of the studies they did describe having CBG content, but it was very small relative to either THC or CBD, like 0.5%, from what I can recall.
That brings up another good point. Whatever our guidance document looks like that we come up with, we would want it to have it framed so that next time we do a review, we could just fill in the blanks, right? So that argues toward keeping UC and Crohn's separate, because if we have additional studies to review in a couple of years, we could just plug those in, say, well, there's been no change here, but there's been a lot more development here. And so, and not only that, separating disease modifying versus symptomatic treatment. And underneath that, disease modifying as evidenced by inflammatory marker change, endoscopic, evidence, and then under symptoms, quality of life scores, bowel frequency, does that seem like a general framework, Lauren, that would be helpful to sort of organize it like that?
Yeah, I think that would be a good approach to the guidance document.
All right. Well, watch your email. We'll send something out, right, Sarah? And we'll
So just for clarification, before we send things out, are we voting to approve to separate the two diagnoses and have their own respective documents, or we voting to keep them the same for now? I just clarification for my team when we work on it.
I'm not sure either. I was
Okay.
in part asking the same question again. Does it make sense to keep them separate because the body of research will grow separately? Or do we want to keep them the same?
I don't think I can answer that, but I do like the idea of categorizing disease modifying versus symptom relief. I think that's hugely important. quality of life would be more symptom relief, but where do we see the disease modifying benefits?
Okay, I guess we'll hash this out in the emails.
Yeah.
We'll figure it out. Thanks, everyone.
All right, what's next then? We have research and we're on agenda item number 7, research updates and education updates by Sarah Ponce.
Yeah, so I'm not sure how many of you are aware, but we do have the study of Utahns' beliefs and life experiences with integrative medicine being handled by the University of Utah Medical School. And they currently, I just want to give you an update on that study. They have gathered a lot of data from their participants, and they're cleaning up the data right now and developing a survey assessment subscale. And then they're also working to complete their website design and content revisions for that website. And once that website goes live, I will definitely share it with you. And then not to put you on the spot, Valerie, but I did notice that you joined. I was going to give an update on the University of Utah Center for Medical Cannabis Research, but I don't know if you would mind unmuting and maybe introducing yourself to the board since you're here.
Hi, everyone. How are you? Thanks, Sarah.
Welcome.
Yeah, so my name is Valerie Ahananu. I am the senior manager for the Center for Medical Cannabis Research at the U. I come from a clinical background and pharmaceutical work, running clinical trials in oncology, virology, and plant medicines. So as far as an update goes, we are in startup. So we so graciously were able to receive funding at the start of July. And we have named an interim director, Dr. Gerald Cochran. So we're now in the process of building our committees and boards and looking to put out a seed grant to start kind of funding some research. So everything is moving along. We also had the opportunity to meet with the Eccles Library and are hoping to develop a relationship with them to help support what you guys do here and start looking at research on a deeper level. I have the opportunity to work with Misty as well, which has been phenomenal. We're so happy to have her, and I think we're chatting with Mike as well. So we met with Russ. So it's been a great experience as we're starting up and trying to look at how we can kind of partner with you guys to move things along. Did I miss anything? Oh, and also we're working with the Genetic Science Learning Center to see how we can consider supporting some of the one-pagers that you guys have that might provide more information for recommendations around some of these conditions that you have listed, as well as potentially putting together some videos to support patient, provider, and pharmacy education.
That was perfect, Valerie. Thank you. That was all the bullet points I had. So
Great. Well, thank you, Sarah. Thanks for the opportunity. It's nice to meet you all.
Nice to meet you.
Thank you so much, Valerie. Welcome. Okay, if we're moving along then, anything else, Sarah, before we move
No,
on?
that's all, unless anyone has questions.
Sounds good. Well, I just think it's awesome that we have so many resources at the University of Utah and the state to do this. It's just a matter of connecting and moving forward. So I'm excited by all of that. Okay, Mike, I guess you're up. Highway safety updates.
Yeah, I can share a few things. Some of this was, in our annual board report, but I can show some of those tables because this was kind of new things that I hadn't shared since last time. I don't know if I can share or if Sarah, you have that document from the Highway Safety Board on the drug and alcohol crashes. I have it pulled up here if I'm allowed to share.
I just made you co-host. You should be able to share.
All right, you guys see that okay?
Yes.
And really what why I ended up working with the highway safety folks was this recognition here. This is a long report. You can see it's 25 pages and there's a lot of different tables and things in here. And I can send this out to the whole group. But they noticed that cannabis had kind of led the pack as far as the most common drug detected in fatal crashes. And so this is not all motor vehicle accidents. This is not all DUIs. This is crashes that ended in a fatality, whether that's one car with another or a pedestrian or a bicycle or a motorcycle. And I think this is probably one of the most representative tables. The numbers don't look large because this is only drivers and only fatal crashes, but it kind of plays out in all the various tables. The question is, what does all this mean? So you see here in each year, and the percentages are confusing because they're across the row, but I'm showing you, cannabis has been the most, usually the most common drug detected in these fatal crashes. And last year, 2022, led the pack as 23 fatal crashes with cannabis detected. There's lots of caveats with this, right? This is what the investigating agency chooses to report into the system. And so does this mean someone who simply has THC, the carboxy THC detected in urine versus a high level of THC in the blood? And that's an outstanding question that doesn't get captured by this data. But it certainly reflects that there's an increase in the number of people on the road who have recently, at least somewhat recently, used cannabis, and it's showing up fairly commonly in fatal crashes, which is kind of bad. And what does all that mean? I don't know if it really gives us conclusions as much as it gives us opportunity to look for more answers. Like I said, there are lots of different charts that kind of slice and dice this in a whole bunch of different ways, and drugs used in combination. We do fortunately see that most people using cannabis and have with other drugs detected, they're usually like antidepressants and things, but we have a fair amount of people driving with cannabis and meth, for instance, and you could suspect that maybe the meth is the worst problem than the cannabis, but you never know exactly. So my update is basically the same thing we've been saying since we started working with the public safety traffic folks. Is there are a lot of people on the road driving with at least some recent cannabis use, though of course it would be really nice to know some specifics as far as like blood THC concentrations versus just a urine test that's positive a week after someone smoked. And we don't know how many of these are people who had active medical cards, and I believe that's remained a difficult thing to marry those two databases, though I know law enforcement gets that information rather quickly when they're investigating any particular case, but it doesn't seem to have merged into this highway safety system of how many of these people are medical cannabis holders. And of course, we have loads of recreational cannabis almost any direction you go except for north out of Utah. So it's highly likely that a big number of these patients are recreational users. So if anyone has questions about this, I'm happy to try to answer. I can, I guess, Sarah, you already have this document and it could get shared with the board, or I could email it out. This is probably not, I don't know about something to have public because this is owned by public safety. And I'm not sure that they have this released as for public use or not. I'd have to double check with Barb Freeman on that, but certainly it could be shared with the board, and that wouldn't be a problem.
Mike, I do have a question. This is Russ. On the depressants, are they including alcohol in that, or is that a separate, that's not listed?
Yeah, so alcohol all gets analyzed separately, like
I would have
this
thought.
table right up here. And so they do alcohol and then they kind of do all other drugs separately. You can look at all sorts of things. They give you all their details of what the methodology is, and it includes drivers and passengers and pedestrians or just drivers and drugs or alcohol, and then the combination thereof and how high were the blood alcohol. So you got 25 pages of tables and figures that kind of pull all that out in different combinations. And I think they probably have an alcohol plus cannabis, which is likely going to be worse than any of those alone. I don't have that table where that is in front of me right now, so I won't scroll through all of it trying to find it, but I'm happy to send this over to you.
Yeah, I would have wondered if there was, more than one drug at one time, and alcohol is almost always involved with.
Yeah, they have separate ones that is comparing all drugs in combination. I believe there's also a table that's alcohol plus drugs in combination, and then how many people are driving with 1, 2, 3, 4 different things detected in their toxicology.
Okay, thank you.
I don't know what the board's response is to this. We've had driving recommendations of, don't drive for a certain number of time right after using. I still think it'd be nice to know how many of these are medical cannabis patients who have active medical cards for the state, but I don't know what it'll take to make that happen.
So, Mike, we're currently working on normalizing our database for our transition to new software platform. So I'm wondering, once our database is normalized, if we'll be able to make that connection a little bit better, but that's something that we can put in the parking lot and maybe get to that once we get our new software and see if that's something we could do to make this whole process easier for everybody gathering information to see if how many people are actually medical cannabis card holders versus legacy users.
Yeah, I think it just goes to show it's good recommendation of all the things that are on the list to talk to a patient about when you're talking about medical cannabis, but just like any other drug that could be impairing, of recommending people that not drive right after they use.
Yeah, my other question is, like you said, Mike, how much of that in the cannabis category is active metabolites versus the THC in the blood? Without knowing that, you don't know whether it had any influence on the driving or not.
Yeah, that I've brought the public safety folks that, they depend on the investigating agency, whatever local law enforcement jurisdiction, to submit these reports, and it's up to them to do it. Like, and we don't have a per se law in Utah. It's anything that impairs you, and so what number would anyone choose to include or not? And I asked the forensic lab that does this testing, and they say, well, we just report these to those agencies. We're not the ones responsible for reporting this to public safety, even though they have all that data lives in the state forensic lab as far as the results of all this testing. But then that would have to be looked at from a separate spot. But then, so that'd be an interesting one too, if we could get just the forensic lab to show us. But they don't have all the crash data, and that lives with law enforcement. So you've got different pieces of data living in different spots and different people responsible for how it's reported to the various systems. And then law enforcement trying to make toxicology interpretations, which doesn't always work. So it's there is a bit of a mess. I think pretty clear that cannabis impairs driving acutely. But what do we do with this fatal crash information? We at least recognize that it's probably not great that the most common drug detected in fatal crashes is cannabis. What does that mean for any individual case or otherwise? Hard to say.
But given the prevalence of cannabis use today, I would expect more people would have metabolites in their system at any given time. That's why knowing that, I think, is important.
Yeah, and is it more common than all the prescription drugs that are getting detected? Because we have things like, maybe if we summed all antidepressants or something, because there's another table in there that looks at citalopram and trazodone and other things that, and I don't know if we know what's the rate of antidepressant prescription and use versus cannabis use among driving folks in the state of Utah. That's an interesting, what is the baseline of those two items to make comparisons of how many are then sorting out. And then you have the much longer detection window of THC, but then you would suspect people who are on a prescription medication would always be testing positive for it if they're currently taking it. So I agree. There are a lot of questions. I have more questions than I have answers mostly about that.
Well, we can't negate the over-the-counter use of hemp-based products that might be higher in THC and leave metabolite use behind, even though the person may never be intoxicated. So.
Yeah, and then I guess that goes to cutoffs, and that would be other stuff to know, right? Are these patients just a whiff over a urine cutoff, or are these patients with blood THC that is of whatever amount? And again, having the specific numbers from the forensic lab would be helpful.
Thanks.
So just so everyone's aware, we just recently in the last week or so came across a statute under driving under the influence and reckless driving that says that A person may not operate or be in actual physical control of a motor vehicle within the state if the person has any measurable controlled substance or metabolite of a controlled substance in the body. But this does not apply to a person that has 11 nor 9 carboxy tetrahydrocannabinol as the only controlled substance present in the person's body.
Yeah, so I can speak a little bit. I do some expert witness work that's private outside from my university and other things, and get involved in some DUI cases. So there is a separate law that is just driving with a controlled substance in the body. It doesn't mean anything that you went too fast or you crashed into anyone or did anything else. It's just you were driving and there's a controlled substance. And that's the limit. It's a misdemeanor. It's not the worst thing out there as far as, it's not a DUI. That's a separate charge. And if you only have the metabolite present, previously any drug or metabolite would make you guilty of that. And now if you only have the THC acid, carboxy THC, long chemical name that you just said, then that's not enough to make you guilty of driving with a controlled substance. And then there's the separate thing that's the affirmative defense for someone who has a medical cannabis card, but then that gets tricky because even if something is prescribed or recommended to you, you're not allowed to be impaired, even if it's recommended by somebody. But that gets a little bit murkier here in Utah. But I believe that law was pretty new in the last year or two, where they added that because it really makes no sense to try to prosecute someone who smoked weed 2 weeks ago for having a controlled substance in their body.
Yeah, we just recently came across what Sarah Dash found it as she was doing her review of cannabis and being a new member. So I was kind of interested to see how that even came to be, because I don't think anyone from our office was consulted on that. So
yeah, I'm sure they would have been talking to Matt Slauson in the state forensic lab and those guys about that kind of detail.
So Mike, I had a quick question for you. Would it help to have a recommendation from this board or even the medical cannabis policy advisory board, having a recommendation to make these databases more integrative?
That would be awesome, and that would catch someone's attention. I know there's desire, among the public safety folks and among us to have that. And I don't know what the barriers are. If you say, Sarah, it's not a barrier of a bureaucratic, we're not going to let you do that, more of a technological barrier is what I'm understanding. And that if that's fixed, then everyone is willing to do it, unless you are missing funding or personnel to make that happen. And then such a statement might get a little bit more energy behind it for you.
That's my thought. Maybe if it was a recommendation from one of these boards, it would incentivize maybe some more resources being put towards that effort. If that's the case, maybe we could work offline and drafting something. I'd be happy to introduce it at the Medical Cannabis Policy Advisory Board meeting, if not from this board as a whole. Because I think it definitely fits here too, because we can't interpret data if we don't have accurate data.
Very true. So knowing the difference there as to who, if we had that distinction, how would that change our recommendation? If we had that link to data, just so I can explain it. Would that change how we recommend people using cannabis and driving?
Well, I think if, for example, if we knew more of the forensic data, for example, that's one of the databases that isn't integrated. If we knew not just if it was positive or negative for cannabinoids, but which cannabinoids it might, we might be able to make a more detailed statement.
The only thing I can think there, that would be, a process change probably for whoever is encountering these individuals, and the cost of having to do maybe serum tests on these individuals. We'll have to have probably a discussion around that as well.
Mm-hmm.
But
if anyone's suspected of, it's up to the investigating agency, but anyone suspected of driving under the influence is going to get blood tested, barring some other things. So I guess that's an interesting question for Matt Slosson's lab of what are they intending to do most of. But I think of what would this turn into, right? The recommendation is going to be the same, whether you're a recreational or medical cannabis user, is don't smoke weed and then get in your car half an hour later. That's inadvisable. But I think it'd be targeting that messaging to the right groups. If we find that our medical cannabis people are great and responsible, then we need to focus our efforts on the recreational crowd. If it's, wow, half of these patients are medical patients, then we need to make sure that we're really emphasizing that to QMPs, and maybe we increase the labeling or signage at the cannabis pharmacies or something like that, that it may direct us of who needs to hear the message more, and where do we need work on the prevention side if we know exactly where it's coming from.
Great.
Yeah, I agree, Mike. I think that's the clinical question is it medical cannabis card holders or not? What's the proportion? That's the question that you could answer with the data. Getting more technical is really hard as far as, impairment and whatever, but if we could answer the question, it's not our card hold members, it's recreational users, then that would be helpful in that messaging.
Okay, great.
That's what we hope for. We hope it's that. We hope it's not, oh gosh, it's a high percentage of card holders that are involved in accident. We hope it's not that, but.
Okay, great. Well, thank you. We'll send out another email regarding this subject to discuss further what our next actions will be.
Awesome. Well, we're still ahead of schedule. Do we have any other board comment topics before we move to public comment? I guess we're good. So we can move to public comment then, maybe Sarah. And I know Mark Viner just had his hand up, but if you could take that away, Sarah. Oh, review. So public comment time period. You have 2 minutes to make your comment. Please raise your hand, state your name and whether or not you have an affiliation, and what that, if you do have, what that affiliation is.
And I'll just be keeping time. So if we reach the 2-minute mark, I'll just kindly let you know. And if you'd like to go first, Mark, that'd be great. Thank you.
Oh, okay. Hi, Mark Viner, no formal affiliation. I work in Nevada as a psychiatrist. Okay, 3 brief comments. The MS, there was a Jazz Pharmaceutical phase 3 clinical trial in June of 22 that the release MSS1 trial where it didn't meet the endpoint objectively for the spasticity. So I don't know, you got to make, even though it's approved in 29 other countries for it, there's still no FDA approved THC product. So to use it for the spasticity for MS, I would just be cautious. There definitely should be additional educational material because nobody talks about sphingosine 1-phosphate, sphingosine, those skeletal muscle trip receptors, it's so complicated. It's not included in any educational programs offered. So anyway, more educate. And then withdrawing, we didn't discuss some of the MS meds, other immunosuppressants like Zeposia, they got a black box warning. If you stop it, the MS will come back worse and kill you worse. And I'm just saying, we haven't really studied long, so I'd be cautious. For the Crohn's and ulcerative colitis, Crohn's is associated with other things like diabetes and rheumatoid. So there's all these other genes and stuff. So, and it's also interesting that Zeposia is also approved for MS and Crohn's and ulcer. So we have to have more educational material on that mechanism of action. Finally, number 3, and long term, does it prevent cancer? Inflammation going to cancer. That's what a lot of the THC studies in mice show. not just its inflammation. So an 8-week study is not going to help. Then finally, driving. The next day effects are different from medical versus recreational use for drive. So I agree with Sep, getting to know if it's a medical card patient, because it's going to come up in legal cases. Next day effects are different for medical versus recreational. That's interesting. Thank you, and I take care. Yeah.
Well, any other comments from the public? Might sound like we don't have any further comments.
Does the board wish to address any of Mark's comments?
Well, I'll speak up. I appreciate Mark's comments. Are always very thoughtful. And the muscle spasticity and spasm issues. Yeah, did we decide earlier that we're going to address that separately? I mean, that's a complicated, as he pointed out, it's very complicated. And I can't remember what we settled on, if we're going to, well, like Mike mentioned earlier, since we have qualified medical conditions as approved, it might make sense that we have a statement for each one. Even though there might be some overlap, it might make sense to have a guidance document for each one, because if someone's looking for that because it's a qualified condition, then they'll be looking for it. And so persistent muscle spasms, I think, is an approved condition. So we might have, feel obligated to have a guidance document just for that. As complicated as it is, as Lauren pointed out, and Mike pointed out earlier, how do you separate disease state from muscle spasm? But it might be helpful to have a document that points out how hard that is. I don't know. What do people think about readdressing the muscle spasm issue?
Oh, I think I mentioned earlier, yeah, and this is in accordance with what Dr. Viner was saying. I think there's several things we could look into the literature about. I mentioned briefly the DNA methylation that actually ties into the cancer comment that Dr. Viner had. Dysregulation of that process can lead to tumor suppressors, silencing and expression of oncogenes, and it's been shown to link to the development of cancer. So that kind of is going into that oxidative stress pathway leading to cancer. There's a lot of preclinical research that is directly applicable to this. So I agree. I think it's something we need to look at, and we could take it in a number of different directions that we can talk about offline.
And Valerie, it looks like you have your hand up if you'd like to comment.
Yeah, I was just considering, as far as MS, when you do also look at some of the recommendations, it's also topicals that are utilized to address some of these aspects. And that was not the approach for Jazz Pharmaceuticals. They actually used spray, like a nasal spray. So that kind of alludes to what Misty is mentioning. There's different modes of action that might actually be more common and are representative of how the patient and prescriber recommend, as opposed to what that trial stated, which are not tested. And I think this is where hopefully, as we kind of move into more human clinical trials, we focus not only on the mode of action, but also the strain, because there are also specific strains and terpenes that impact the system and how it's actually managed through the endocannabinoid system, that affect particular indications over others. So I think there is data to support it as well. And so to not, jump the gun too soon. As far as saying that it is not effective, I think it's the mode of action that could be looked at and considered. And maybe that's a recommendation that is added to the one-page sheet that you guys provide. So usually in combination with CBD or a topical, it can be really beneficial for patients. So that's all. I just wanted to comment on that. Thank you.
Well, thanks, Valerie. Any board comment? Well, thanks again. I think you illustrated how complicated this gets. It gets complicated really, really fast when you start listing all the variables that to take into account. So, but it also makes it exciting. This is a area that we can go a lot of different directions, like Misty said. All right, additional comments, public comment. Okay, any objection to leaving early?
Do we have a motion?
Misty, I assume by the raised hand that you're motioning to adjourn.
I would motion to adjourn.
I'll second that.
We have a second by Russ. Yep. Okay, all in favor of ending this meeting and thanking everyone for attending, please indicate. Any opposed? Want to stay longer? All right, well, again, thank you all for participating and for your comments today. Again, like I said, I think this is an exciting place to be, an exciting topic.
Department of Agriculture, this is Kyra.
Oh, Kara, do you have a comment? Okay, maybe not. All right, well, thank you all. We will stand adjourned till January. Watch your email and we'll be in touch.
Thanks.